Hi, and welcome to the Anti-Waffle podcast with me, Embel Sharnaila, and Marva Gregorio D'Souza.
Hello!
And together we'll try to talk about research without any gobbledygook. Each episode we'll be talking to a researcher who will discuss the work they're doing, looking at why this research is important, and asking how did they get into this field. We hope it will be informative and interesting and bring a bit of the academic world into the real world. This week we have Dr Yogini Jani with us. Hello.
Hello.
Thank you for joining us.
Thank you. Pleasure.
Would you like to start by explaining some of your research, please?
Absolutely. I'm currently working as a Health Foundation Improvement Science Fellow, looking at research involving penicillin allergy and patients who report that as one of their sort of status, if you like. Thinking about antibiotic prescribing for those patients in the context of safety. So how can we safely prescribe antibiotics to patients with penicillin allergies, thinking about harm avoidance, but also thinking about resistance, which is a really big thing with antibiotic use. So that's my current research area.
Wow, a very important one. That's antibiotics are all over the news at the moment, aren't they? With the just the overprescribing.
Exactly.
Yeah.
So there's obviously the overprescribing of antibiotics, but clearly they're life-saving medicines. So we need to make sure that when they are needed, we give them, but we give them as safely as possible. So in my research, what I'm looking at is 1 in 10 patients tell us that they have a penicillin allergy.
Yeah.
If you read research more widely around that topic, the reality is that not all of those patients will have a real allergy. They may have side effects, they may have intolerances, they may have, as a child, been told you might be allergic to this, but you don't have a level of certainty that they are truly allergic to penicillins. What that means in practice is, if you're not sure, so typically in my day job, which is as a consultant pharmacist at University College Hospitals at London, I look at when things go wrong, and patients may come in through the door who need an antibiotic, and the doctor will ask them if they have any allergies, and they might say, yes, I've got a penicillin allergy, but it was a long time ago, I don't remember what was wrong with me. The doctor has to make a choice of, do they give them the best antibiotic for the infection that needs to be treated, which might be a penicillin group, or do they give them something else, which may still work, not as well as the penicillin, but good enough, but kind of then enters this realm of not quite optimal prescribing because you're using an alternative penicillin. So in that kind of situation, we want to try and get as many people the right antibiotic as possible. So when you look at broader research around this area, there's a lot of evidence starting to come through that although 1 in 10 people are telling us they have allergies, actually a lot smaller number are truly allergic. But when you're that doctor at that moment in time, how do you decide what's your risk judgment around should you prescribe or should you not?
Right.
So in my fellowship, which the Health Foundation are funding, which is a 3-year project, what I'm looking at is the behaviours. So the understanding of when you ask what is an allergy, what does that mean to the person who's asking the question? But actually, how is the person who's hearing the question understanding that term, and what does it mean to them? And then what is the discussion that follows around, you need an antibiotic. If you tell me you're allergic, I may give you something else. If it's not an allergy, I can give you a penicillin-based antibiotic, and that might help your infection get treated quicker or better or whatever. So it's kind of finding that balance around understanding that description of penicillin allergy and thinking about how best can we use antibiotics in that group of patients. So you're not creating harm for them by going ahead and giving them a penicillin and actually they have a true allergy and they end up on an ICU.
Right.
Or you're avoiding a penicillin, but actually that might have been the best antibiotic for them. So it's the kind of, on both sides, there's an element of harm to be considered. Yeah. How do you weigh up that information? Right. So I'm really interested in the behavioural side, but also looking at risk from a error, but also a resistance perspective.
Right. So with the penicillin allergy, What's the sort of like worst case scenario?
So the most severe reaction you could get would be an immediate anaphylaxis. So you get the penicillin and literally within minutes, if not seconds, you will have a reaction, which is an immunological reaction. Examples of the symptoms you might get is your body starts to shut down, you can't breathe, your face starts to swell up, and that, if not managed immediately and quickly, could cause death. So, obviously, if somebody knows that they've got a serious, severe, true allergy, then you absolutely do not want to give them a penicillin.
Right.
But because there is so much kind of uncertainty, and I think part of it is because people use the term allergy every day to mean quite slightly different
Sometimes
things.
people use it if they can't stand the smell of something. It's just
no.
Sometimes it's more of an intolerance, isn't it? More than an allergy or like a dislike.
So there is the sort of...
the taste, I must be allergic.
Exactly. So I think the medical sense of what do we mean by allergy and the sort of immune modulated response that you have when you're faced with, in this case, penicillin, compared to it gives me severe diarrhea. Of course, that's a side effect. It's a known side effect. It may be severe. It may be highly unpleasant. But if you had to make a choice of the only antibiotic that might work with you versus severe diarrhea, sometimes you have to make those choices. Right. So yes, there's something about the terminology allergy and how people understand it, but then in a medical and a sort of healthcare environment context, every day doctors, nurses, pharmacists are having to make these decisions of, let's use antibiotics properly, but let's also keep patients safe if they're saying they might be penicillin allergic, and sort of balancing those two.
When did you start the project?
So I started, my fellowship started in April 2017. It's an area that's interested me throughout my career. So I've worked as a medication safety officer and pharmacist for a number of years now. And like I said, I get to hear about, unfortunately, when things go wrong in medication-related practices. And I will almost every month see 2 or 3 reports where the report comes in and it says, patient said they were allergic to penicillin. We managed to prescribe and give them penicillin. And then it's almost a 50-50 chance of, but they were absolutely fine, nothing happened to them, so we don't think they're penicillin allergic. Or they did have a reaction, but we managed it and they were okay, or they did have a reaction, they needed to be looked after a bit more in an ICU type setting, but they were okay after that. So it's that kind of, people have to make a decision about treating, but if you're getting a 50-50 outcome, kind of understanding what we can do to help people at that point of care to say, what would make one person prescribe penicillin in that situation, and what would make you not prescribe penicillin in that situation. So I'm very much interested in what are the factors that influence the decision making in that sort of uncertainty of should I or shouldn't I? I'm not quite sure how true this allergy is.
So are you looking at it retrospectively? Are you looking like sort of like interviewing actual cases where things have gone wrong, or looking at ones that have gone right as well? Or
so I'm looking at a bit of both. So my fellowship is made up of different chunks of work, if you like. So there's one piece around finding out from patients, some who said they had allergies, some who said they didn't, what they understood by the term allergy, and just unpicking that a bit more. So, and how willing would they be, for example, to be tested where they say they've got an allergy? Would they be willing to try a dose under supervision, under medical supervision, where it's like, I really can't remember. I think I might have had it a month ago, but I still have this in my notes that I have penicillin allergy. And some people are willing to have that test of, let's try a dose. I'm in a hospital. If something happens, I'm in the right place to. So they're, again, not part of my fellowship research, but more generally, there is there is interest in the NHS, but also worldwide in, can we sort of find out and try and have a more accurate feel for people's allergy status. So in my case, I was asking people about their understanding, but then also going out to doctors, nurses, pharmacists, but also the undergraduate students for each of those professional groups to say, if you had this hypothetical scenario with a bit of information, would you go ahead or not with the penicillin? So doing like a survey study. And with that, what I'm trying to find out, for example, is what information is influencing people's decisions. Mm-hmm. So it's not that healthcare practitioners, aren't necessarily kind of, we'll risk it, it'll be fine. That's not what it's about. So they're obviously using information to guide their decisions, because they are walking that path of, I want to use antibiotics as best as possible, but I also want to give my patient the best treatment with the least harm. Right. So what's affecting their decision making? So in the scenarios that I'm sharing in the survey, I'm changing a few things. So in some scenarios, there might be a description of a really serious reaction in the patient. So is it the severity of the reaction that influences the decision making? In other scenarios, it might be that the source of information, so is it the patient telling you that they have an allergy, or is there a test report from an allergy clinic that says this patient is allergic? Right. And does that change people's decision making? So I'm trying to find out, what are all these different factors that can influence? Is it because the GP system has a record but they've never had an allergy test, the patient isn't 100% sure? How does that change people's decision making? So I'm trying to understand the factors. So that's a second piece of the work. Right. Then I've got a third piece of work, which is basically looking at retrospectively where things have gone wrong. So there's a national reporting and learning system which captures information about patient safety incidents. And I'm looking back at that data to say, is there anything in that data that we can kind of try and understand or analyse as to, so when did harm happen, or when did it not, or what were the preventative things, so what kicked in to stop harm from happening. And sometimes it's technology, so you've got electronic system and the record said penicillin allergy and an alert came up and therefore that stopped somebody from doing something. Or is it because every prescription that's written in a hospital will get reviewed by a pharmacist and a nurse before they dispense or give those medicines. And at that point, you get a sort of second check, or somebody comes up to you and say, are you sure? Because I found this bit of information, or I found that information. So do we want to go ahead with this or not? So you kind of have that dialogue. So is there something about that team working which makes for safer practices or checks? Or so there's a retrospective piece around what are the themes and trends, both in terms of bringing safety in, but might have predisposed to the harm going through. And then a final bit of work, it's a 3-year study, so it's kind of, it's actually working with GPs, because one of the things that does come through, of course, is that patients tell us what they're allergic to, and we also can, in a hospital setting, can get a summary from the GP about relevant information, of which allergy can be a part of it. So I've been working with a very small group of GPs to say, well, what happens in your practice? How many patients are telling you they're allergic? And actually, if you went back in their notes, and the GP notes are likely to be from hopefully birth until whatever, unless they've moved, can you go back and see when the allergy flag came onto that patient's record, and how much certainty as a GP do you have that this is a true allergy as opposed to a side effect or a reaction? So doing a bit of work with GPs as well to try and kind of look at that whole spectrum of patient understanding, what ends up in a GP record, and everything in between around predisposing factors, things that influence people's behaviours, so patient as well as healthcare professionals, in either, yes, you can give me a penicillin because although it says it's an allergy, I know that last time it just made me feel a bit nauseous, versus no, absolutely don't give me that because I went to the allergy clinic, or I came up in hives, or, some really serious reactions. So, don't even touch that with the barge pole.
What are you hoping for to be there for the outcome? What are you hoping to produce? A sort of a policy or some sort of guidelines, or how are you hoping to tie it all together?
I think so when I started off, it was very much, I'll be able to bring a toolkit out and people can go and do things with it. And almost 2 years in, I think what I've realised is that, there's a lot going on there. So at this stage, what I'm hoping the outcome will be is being able to review the systems by which we record or capture or ask about this information. So actually, how do we check every time that the information in front of us is reflective of a true allergy or not? And as part of that, there is, the work with the GPs around, well, can we build something into their routine review of medication? So every patient's supposed to have an annual medication review with their GP. You can have reviews with pharmacists for medication. So as part of those processes, can we build in something explicitly around allergy status, working with other groups? And like I said, this area is of interest globally, not just started off as my fellowship, but it's a bit like when you have pregnant friends or family, and because there's somebody who's pregnant, everywhere you look, you see pregnancy.
Yeah.
I feel a bit like that with my project because I'm interested in penicillin allergy.
Yeah,
Suddenly now everywhere I look, everyone's doing work on penicillin allergy.
Everyone's got a yellow car now.
Exactly, that kind of thing. So what is coming through and is that, there are now risk stratification tools that are coming. So groups in Australia, groups in the States, and one of the groups I'm working with in Birmingham have got these risk stratification tools. So you ask a series of questions, you use the information that's available, and you basically try and determine whether the likelihood that this patient has a true allergy, and is it a high likelihood or a high risk that their allergy is true, or is it a low risk that their allergy is true? So kind of make an assessment of low risk, high risk, and then for the low risk patients, what can you do to try and confirm or reframe that allergy flag? So with the group in Birmingham, what we want to try and do is see if you can, and even with the group of GPs, what would it take to actually offer them a dose of oral penicillin in a supervised environment, and then be able to say yes or no, we think you are really allergic. And then for the higher risk patients, can we create a pathway which says, actually, we're not sure, there isn't enough information, you haven't been allergy tested, but there is national guideline from the National Institute of Clinical Health Excellence. So there are nice guidelines which say, if you suspect a penicillin allergy, you should follow this pathway, which includes allergy testing. That guideline was published in 2014, and we know that the uptake of that is patchy. So through this work, for the patients that are stratified as higher risk, can we kind of set them on that pathway so that they are then being referred for formal allergy testing, and then you have more certainty around, yes, they're definitely allergic, no, they're not allergic. So I guess as an output, whilst I thought I might have 2 or 3 interventions I was going to be able to test, what I found is that I'm on that journey of what systems do we already have about asking people about their allergies and recording their allergies, and how can we refine them and how can we improve on them so that we're more actively asking about allergies, more actively thinking about stratifying patients, thinking about removing that, being able to remove that flag if it isn't a true allergy, but being able to confirm that flag if there's a high index of suspicion or suggestion.
Do you think it would work to use maths to do it? The figure with the risk factor. So, like, if certain aspects of whatever they have or their experiences gives them a score, and then once they're over a certain score, oh no, you definitely can't, or you must be given.
You mean like a mathematical model?
Yeah.
Potentially, and through all my thematic analysis and the sort of survey work that I'm doing, what I'm trying to get to is, are there particular factors that have greater influence on the outcome that's seen? I haven't reached the stage where I've got enough information to be able to say, let me plug that into a model to see, what the sort of risk factors are in that sense. The potential is there. I think it is quite a diverse, messy, complex, whatever you want to call it, arena, in that it isn't one penicillin, it's a group of penicillins. And then within your patients, you've got the sort of age, comorbidity, everything else going on. And then in terms of the reaction, if you look at the NICE guidance around it and the possible reactions you can have, you kind of get your immediate life-threatening anaphylaxis type things. You've then got your sort of slow burner, so you might not see the reaction until a little bit later, and then you've got the really late phase reactions. So actually there's quite a lot going on there. So I would say it's not impossible, probably not within the scope of the time that I have left to be able to develop a model. But
is there an element of working with the public and sort of trying to educate them, particularly in the allergies area?
So that is, and I started off by saying, it was really trying to understand what everyone's understanding of, or how do you use the term allergy almost, it doesn't matter in what context, but what do you mean by allergy? And absolutely, so I think there is a piece of work that can be done around charities like Allergy UK, so they're part of my advisory board, and just thinking about, well, what's the general understanding use of the terminology allergy? And then how can we better communicate? So thinking about co-production with patient and public, and thinking about how can we work better so that we can have these conversations around medicines related allergy in a way that allows both parties, the healthcare professional but also the patient, to be clear about, this medicine didn't agree with me, the penicillin did not agree with me, but if I had a life or death situation, I'd be happy to have it. If it meant I didn't have to stay in hospital or my infection would get treated a few days earlier or whatever, I'd be happy to have it. Compared to, it's an allergy, it might kill me, and don't ever give it to me. So how can we capture those different types of reactions in a meaningful way, so that you're always talking in a similar way about allergies? So as professionals, we're asking in a similar way, but also as the person who's providing that information, you're providing it in a similar way. So what can be done around that? And my fellowship is improvement science, and that's very much around taking an idea and sort of running it through small tests of change, but recognizing that I can have that conversation with a group who may be very engaged, enabled, aware, and the way that I present that to them might be very different to somebody who's newly diagnosed or have just had a reaction. So it's a kind of, what are the contextual factors that may or may not make even that discussion work? What would it take to have that discussion? So great scope for patient and sort of general public involvement within that. And again, that's one of my, I'd love to do this. So it's definitely on my list of follow-up areas to take forward.
And is there a way, if public wanted to be involved, that they could be involved in the study?
So at the moment, within the scope of what I'm doing, it's not something that I had planned for. But certainly as an area,
since 2019, I would have thought by now that there would be some form of allergy testing that can be done in the GP surgery.
There are. I'm not an allergy expert in that sense. So again, it is possible, it is feasible, but the way an allergy manifests is not always through one pathway, and that's
Right.
why the reactions that you see, the sort of immediate versus sort of medium term versus long term varies, because the immune pathways through which it does might be slightly different.
Right.
So even with allergy testing, when people talk about allergy testing, it isn't always one test.
Right. Yeah.
You can send off for a blood sample, which will tell you whether you had a sort of immune response immediately, and you can get a number, and that will say that's highly likely.
Yeah.
People get like patch tests, so you kind of, you know, put a little bit on and see if there's a bit of a reaction. And you can, like I said, you can do what's called an oral challenge. So you basically say, okay, let's just give it to you by mouth and see what happens. And if you react in the way that you thought you were going to react, we've confirmed that you have an allergy. So there's multiple ways of testing for allergies. And quite conceivably, some of them can be done in a GP environment. And certainly my work with the GPs, and where I'm going with that, with these small tests of change of what is possible, is saying, let's start with this structured review of, you've got a patient with a penicillin label. Are they high risk or low risk of having a true penicillin allergy? If they're high risk, or you're almost certain, because if they say my throat swelled up, my face swelled up, I couldn't see, I couldn't breathe, you don't need to send them for a test. You know they've got an anaphylactic type reaction. That's enough to say high level of certainty anaphylaxis. You don't need to do any more with them. But if you get some sort of vague responses and you think, well, if I re-challenge them, they could go into full-blown anaphylaxis. I don't really want to be doing that in my GP surgery. You might put them on a pathway which is, okay, you're somebody who comes into me regularly, you need antibiotics regularly, so actually it would be good to know whether you really are allergic or not. I'm going to send you for formal allergy testing, and I don't want to risk it in the surgery because you fall in that high kind of likelihood category. The ones where you think, okay, you got diarrhea, you were a bit nauseous, how do we feel about this? Do you want to take a dose and see how you get on? So that's kind of the alternative option. And something like that, the GPs that I was speaking to said if they had the infrastructure to support them, they would be willing to consider it. So it's not that they're not interested, but it is then what systems do you put in place to be able to support that? Because it is an unpredictable reaction. So they might be fine and they can go home after a few hours of observation, and then 24 hours later be able to say, I'm still fine, and 48 hours later say, I'm still fine, and then that's okay. But if they react, you then need to have that pathway of being able to call an ambulance or give them the intramuscular adrenaline or whatever it is. You need that kind of system there. So it's being able to set that up. I think that's part of the where next. It's being able to take that GP piece of the work to say, are you interested? Would you be willing to consider? Let's start with how many patients we think this might involve. So in one GP practice, they asked about 70 of their patients if they had any allergies and what they were allergic to, and nearly half of them said they had an allergy, and nearly 2/3 of that half said it might be penicillin. And then when they started looking at their notes, they were able to break them up into high risk, low risk, and then there were quite a lot of low risk. So actually with those, you could then have the conversations and the planning and so forth. So kind of starting that with one GP practice to see, is there a model that can come in? And this is where I was going with it. If you need to have an annual medication review, could you use that structured review format at that point to say, we're doing a medication review, we're also going to do your allergy review at this point? And you would need to do it on an annual basis because you might have had things in between which might change your allergy status. So you kind of just build that into something that's normal part of service. But the where next, having done that review, it's no good just saying, I think you're at high risk of it, and we'll just file that away. So it's thinking about, well, what might the infrastructure look like to be able to take it to the next step.
So how did you get to this area of research? What's your background?
So I'm a pharmacist by background, and pharmacists are very much interested in medicines, and very implicitly and in some role very explicitly safety is a part of that. So everything a pharmacist does, whether you're in the lab discovering new molecules, in a lab making up the formulation of these things, in a pharmacy, doing the sort of clinical review and supply of the medicines, or in hospitals going out and about on the wards with the consultants, the nurses, on ward rounds doing patients' review of medicine and so forth. You're always thinking, is this the safest medicine for the patient in front of me in the formulation that's going to work best for them? Whatever kind of realm of pharmacy you're in, research, industry, all the way through to in front of a patient, you're always thinking medicines and safety. And with that thread pretty much has run through my career. So I've been a hospital pharmacist through and through. I tried to work in community pharmacy and realised that I find the sort of variability and the sort of breadth of what you see in hospital pharmacy more suited to my interests and strengths, I guess. The one thing I didn't do very much, which for most people when you say you're a pharmacist, they think large chain pharmacy, dispensing, supply.
Yeah.
And if I had to sort of try and work out how much time I've spent actual dispensing, I would say it's incredibly small amount. So I've always done more the sort of clinical review, making sure it's the best medicine in the best formulation for the patient. So dispensing is a kind of core part, but it's a small part of what pharmacy do. So throughout my career, I've been involved in projects, even as a junior pharmacist, looking at, what can we do to make medicine safer, make sure they're given? How can we better communicate about medicines when patients come in and out of hospitals? I worked in emergency departments, cancer outpatients and inpatients departments, in intensive care units. So I've had quite a diverse kind of exposure to what palliative care, so really diverse exposure to what pharmacy practice can allow you to do. But safety was always a theme within that. And then, so I carried on doing that, and in about 14 years ago, somebody said to me, would you like to do research? Because I was getting to the stage of NHS, red tape, all of this. Yes. And it was a case of, I'd never thought of doing research. Tell me more about it. And they were like, well, it might be right up your street because it's about reducing medication errors. Great Ormond Street are putting in a new electronic prescribing system and they want to see what impact that's going to have. So they're looking for somebody to do a PhD. And so, that sounds really interesting. Never in my life thought I was ever going to do a PhD. I wasn't on this sort of trajectory. Mm-hmm. So came and spoke to the professors here, who ended up being my supervisors. So one of them, Nick Barber, who's done a lot of work on medication errors, medication safety, the role of technology. And then the other, Ian Wong, who'd done a lot of work around paediatric pharmacy and research for children and medicines for children. So I was successful in my application for that PhD, went and did my PhD looking at electronic systems and prescribing at Great Ormond Street. Really enjoyed being able to have that kind of inquiring, open approach to safety, sort of seeing it through the lens of theory and other perspectives of inquiry. It's science-based, but it's a different approach. So pharmacy is a very science-based degree, and this kind of brought a more health services research focus to the work that I was doing. So did that, and then at the end of the PhD it was a case of, well, what do I do now? And also realised during the course of the PhD that I'm not a pure academic because I missed my patient contact and I missed the healthcare professional side of things. So I was lucky enough that the hospital and the School of Pharmacy were willing for me to do a split work role. So I went back as medication safety pharmacist, but kept a sort of 1 day, 1.5 day a week research commitment. And through that, I've been able to supervise undergraduate students with research projects and supervise PhD students, but at the same time being close to patient and practice around, bringing the sort of systematic, broader perspective review of improvement and inquiry into the health side, but also making sure that research is actually going to have an impact on the way we practice as far as safe medicines use go. So it seemed like a nice bridging of the two.
Have you always wanted to be a pharmacist? Even when you were a little girl?
No. And I have to say, very disappointingly, I don't think I know what I wanted to be. So at the time that you had careers advice and, you did your GCSEs and you were going to do A-levels and you got the whole, well, what do you want to be? So I don't know what I want to be. But I liked sciences. So I very boringly did maths, physics, chemistry as my A-levels. And then from there it was, okay, what else can I do at degree level? And so although I didn't know I wanted to do pharmacy, what I did know is I really enjoyed sciences.
Yeah.
But as summer jobs, I used to work in retail, clothes shop, and I did things like customer services. You always had irate people shouting at you and all that kind of stuff. But there was something about the sort of dealing with people that I really enjoyed. So thinking about careers which would allow me to pursue science, but also be able to have a connection with people, in my mind, again, not knowing the breadth of what pharmacy offers, it was very much that high street chain, science, people, pharmacy seems like a good place to go. So I kind of stumbled into pharmacy in that way, but best decision ever. And then again got slightly itchy feet after having been in healthcare for a few years and thought, what else can I do? And the Health Foundation Improvement Science Fellowship came up. And again, that was very much about bringing a research perspective into improvement. So, how can you use the sort of scientific underpinnings to enable improvement in a systematic, consistent way? And so I applied for the fellowship and was successful at that as well. And at that time, the whole allergy thing was already on my mind because, it's something that feels like it's really easy. If somebody tells you they're allergic, why on earth would you give them something that they're allergic to? Surely you wouldn't. But actually, the more you unpick it, the more you realise. So I had all of that brewing in my day job, and the Improvement Science Fellowship was about, being able to do things in a sort of strategic, systematic way. So that's where I am now.
Can I ask you to sum up to the public why this research is important?
This research is important because increasingly people are aware and report allergies, not just to medicines, but generally the knowledge that allergies occur. In the context of medicines use, we know that antibiotics are a precious medicine and we need to use them properly. In order to get the best out of antibiotics and to be able to use them properly, one factor that influences the choice of antibiotic you will get, if that is the right thing to do for your treatment, will be whether or not you're allergic. So it is important that that flag of I have an allergy is as accurate as possible to allow you to get the right treatment, to allow the people treating you to help you get the best out of the care they can provide.
Do you think the public needs to be more involved in the prescriptions that they're given? Or do you think they should be just taking them blindly because the doctor who knows what he's doing or she's doing has prescribed them?
No, absolutely not. I think it has to be a partnership. In answer to, they shouldn't take it blindly is what the no was for. Yes, they should be very involved, is the answer to your question. I think any treatment that you receive or choose to receive is a choice, and it has to be a shared agreement about what will happen, because we know that a prescription can be written and given and dispensed, but 30 to 50% of medicines for long-term conditions are not taken. People will not take them. So actually we need to understand why aren't people taking them. Yeah, and if you don't have that sort of shared agreement of this is the best course of action for you for this treatment, we will always have that problem. A lot of medicines are wasted year in, year out, partly because they're not taken, partly because they're overprescribed, in the sense of if you're not having that dialogue, do I need this? Do you want this? What's the best for you? then you'll always have a mismatch of what is the treatment goal. And I think a treatment goal has to be a shared treatment goal. If, as an individual, I don't want a treatment which is a tablet, that needs to be a shared decision, that needs to be communicated. So I think it has to be a joint decision.
Thank you very much for your time, and thank you for everybody for listening. We're going to put links up on our website, which is antiwafflepodcast.wordpress.com, and our Twitter account, which is antiwafflepod, and we'll make sure all the links are there so you can follow up on the work. Please do get in touch, as we'd love to hear from you. Bye.
Bye.
Bye.